Very good afternoon to everyone here who is watching us live. So I'm Dr. Hrct. I'm a consultant interventional pulmonologist associated with Aster CMI Bangalore, the Department of Pulmonology. So sitting with me today are members and integral part of the Aster ILD clinic. So we have Dr. Sunil here, who is the lead consultant, interventional pulmonologist, Department of Pulmonology, Aster CMI. We have Dr. Sudhir Kali, who is the head of radiology at Aster CMI Bangalore. We have Dr. Chetana, who is the consultant rheumatologist, Department of Rheumatology, Aster CMI Bangalore. And we have Dr. Richa Jain, who is consultant radiologist associated with Department of Radiology, Aster CMI Bangalore. So what we are going to discuss today is about a disease called interstitial lung disease. So let me just run through you about what is interstitial lung disease. So interstitial lung disease is basically a heterogeneous group of lung disorders that are primarily characterized by irreversible scarring in the lungs, which is progressive and often causes a significant impact on day-to-day functioning and quality of life of a patient. Now, when we say interstitium, we are primarily talking about the most important anatomical unit of the lung that forms the basis of the primary function, which is the gas exchange involved in the lungs. So when the interstitium gets thickened, it becomes less porous to oxygen, thereby becoming a barrier where it has to actually facilitate life. Now, from a survey in 2019, it was seen that about an estimated 25 million people suffer from interstitial lung disease. Now, if you put all those people together, it is almost the size of the population of Australia. Now, what that spells for a disease of this nature is that it is a sitting iceberg waiting to be discovered, and this realization is already happening at the level of the medical community. The fact remains that the disease dissuades a classic approach and many a times missed by physicians, masquerading itself as a non-resolving pneumonia, sometimes termed as asthma outside, sometimes termed as chronic obstructive pulmonary disease, and sometimes plainly put as a never-ending cough. But what it demands is a specialized approach with a keen ear and eye for things, a systematic process of exclusion and discussion, and the evolving inventory of diagnostics that they are able to clinch the diagnosis quicker in an established method of multidisciplinary discussion. And this is the worldwide accepted norm and method for coming to a satisfactory diagnosis. The Aster ILD clinic, we are proud, was built in 2018, and we have attended to and diagnosed, discussed, and helped over more than 300 different patients with this disease. Some of the prevalent diseases which we have come across during our clinic are idiopathic pulmonary fibrosis, hypersensitivity demonitis, connective tissue disorder associated ILDs, which we shall be further discussing as we go forward. The clinic, in our experience, has helped to streamline these patients and deliver care in a more systematic manner that reflects in better patient outcomes and satisfaction. Today, I have here with me the multidisciplinary team that has come so far in delivering fantastic care to such patients to share their experience independently. And let me throw some questions at each of my team members so that we can go through the various nuances of interstitial lung disease. Firstly, I would like to ask Dr. Sudhir Kale, the head of the department radiology, on what is the role of radiology and how does radiology make us understand ILD better? Do patterns tell us a story?
Yes. Nice question, Dr. Srivatsa. So firstly, ILD means interstitial lung disease, and radiology and ILD, if you want to use radiology as an imaging tool, we have Hrct Scan, which is the imaging modality of choice in patients with ILD. So Hrct means high resolution CT scan, right? So in high resolution CT scan, we try to look for some classic imaging patterns which has been described in patients with ILD. So to just begin with, firstly you have something called as a reticular net-like or a mesh-like appearance in the lungs on a CT scan. So this is called as a reticulation. So that is one of the pattern. Nextly, we have something called as a ground glass densities. So what are these ground glass densities? Basically, it's a glass which is having a matte finish. So you can find that kind of appearance in the lung. Okay, when these two combine, when they overlap with each other, we tell it is having a crazy paving appearance, like a pavement of tiles, right? So these can be seen in ILD. Then we have something called as honeycombing in the lung. So I think few of you would have seen, like in the CT scan reports, honeycombing present, honeycombing absent. So basically honeycombing are nothing but small cysts which have a common walls and they are arranged in layers, generally in the outer zone of the lungs, and it can be in 1 layer, 2 layers, 4 or 8 depending upon the severity of the lung disease. So honeycombing is also described as one of the classical feature. Then we have something called as traction bronchiectasis. So what this means is the airway, the bronchiole, as it gives like the terminal bronchioles, and generally they are smaller in caliber with the adjoining pulmonary vessels. But in interstitial lung disease, especially when the fibrosis, when the scarring increases, these kind of get dilated. They become almost 1.5 to 2 times the adjacent vessels. So, and then we have something called as a nodular pattern in the lungs. So like there will be multiple tiny nodules in the lungs, like just like a starry sky appearance in the night. Okay, we can find that nodules. So all these are very classic imaging patterns. Radiologist uses them in diagnosing interstitial lung disease. So then, so one part is diagnosis of interstitial lung disease. Next part is about also trying to look for the type of interstitial lung disease. And thirdly, helps in the pulmonologists, physicians for monitoring, like treatment monitoring. Like say, like if it is an acute phase illness or is it a chronic illness, all these can be pointed out in an HRCT report. And then subsequently, it also helps in the follow-up of the patients, like the treated patients on treatment, say after 6 months or 1 year, is the disease completely gone or is it remaining status quo as a stable disease, or is it progressing, whether more of the lungs are getting involved. So I think thereby all these HRCT imaging patterns, I mean to sum up, I mean definitely will aid in the guidance of the diagnosing and treating ILD.
Thank you, sir. So as you can see that the radiology speaks for itself sometimes and tells us a tale of what's actually happening in the lungs. But is that enough to make a diagnosis of interstitial lung disease? So a big chunk of our patients have associated autoimmune diseases, and looking through it at that lens has made us realize and recognize many patients with interstitial lung disease early. How does it define the prognosis in such a scenario? No, Shetan.
Yeah, so by autoimmune diseases, we are particularly referring to conditions like systemic sclerosis, rheumatoid arthritis, inflammatory myositis, which are all well known to be associated with interstitial lung disease. So we will be following up these patients regularly from the start of their illness. So if they develop symptoms of interstitial lung disease like cough or breathlessness, so we are sort of adept to picking up the ILD early by appropriate imaging and other investigations. And also in patients like systemic sclerosis, at baseline itself, we will be investigating them for ILD, because the development of ILD in autoimmune conditions like scleroderma happens very early, within the first 1 to 5 years of disease onset. So by way of early diagnosis itself, the prognosis for connective tissue disease ILD is better compared to idiopathic pulmonary fibrosis. And generally the prognosis for all the CT ILDs is better when you're looking at the prognosis of IPF patients. But when you are looking at all the connective tissue disease patients, so patients who develop ILD, they have a higher mortality compared to the general population or compared to patients who do not have interstitial lung disease. So the key is really to diagnose early and start them on treatment early to prevent worsening of ILD.
Thank you, ma'am. So going on to the next question, I think this is an apt question for a pulmonologist working at the edge. So most of our ILD patients are really sick, and sometimes they might require a biopsy to diagnose the interstitial lung disease. So the question is, tissue has always been a big issue, especially for a diseased lung and a very sick patient. How has diagnostic technology evolved to give better answer to these patients? Dr. Sunil.
Thanks, Prasad. It was a wonderful question. Actually, that will be a pinnacle of what is the discussion, what we're having today. Basic thing is that interstitial lung disease, I think it has revolutionized from past 4 to 5 decades actually. The way it has revolutionized in terms of getting more clinical into more objectively driven radiology with that of a biopsy to concretely explain this process in a very comprehensive way, so that which can be addressed through proper molecules in terms of therapeutic aspects also to address all this at each and every level. Now, when it comes to a disease like ILD, where we have more than 1,000 variables, different types of ILDs, boiled down to 9 patterns of what radiology to sum it up. So when it comes to 2 clinicians sitting together, we have an agreement of 10 people, 4 people we can comfortably say that's based on the history when it comes to age, sex, at the same time any occupational, environmental factors, all these things contribute to give some sort of clue about, and also somebody with oxygen level slightly on the lower side, or on a clinical examination we have bilateral, basal, crackers, all these things points out towards the possibility of an ILD. Now with that, when you have an agreement of only 4%, can the radiology comes up in the picture, where HRCT has revolutionized the way in which we look at the ILD patterns, where they tend to agree too often actually. When 2 radiologists sit together, they'll come to consensus agreement to the tune of 8%, 8 out of 10 patients will get a diagnosis. But when we have a sharing of thought process from among the clinicians and the radiologists, there the pickup rate drops actually, where our agreement comes down as less as 4 to 5% or maximum 6%. So can we increase this sort of an yield actually in terms of getting a concrete diagnosis where the tissue is the issue? Still now, when it comes to ILD patient, no doubt they are sick at the 6th lot because of the scarring process, because of limited resource what they have. So we need to give a concrete answer with ensuring the safety as a predominant thing. Where the gold standard for till date is also a surgical lung biopsy. But unfortunately, if you see the data in the last 10 years data, probably the mortality associated with this of a surgical lung biopsy is 1.7%. Anybody who is going diagnostic modality and a mortality of 1.7% may not be acceptable in this arena. Can we go with less invasive or a sort of a safety profile which can at least get these things, negate your diagnosis with the ensuring good amount of safety? There comes the role of a tissue with a biopsy using a cryo lung biopsy. This is a modality. When it comes to bronchoscopy modality, there are 2 things. One, transbronchial lung biopsy, which can be done on an OPD basis, where your bronchoscope goes to the area of interest, get the biopsy. At the same time, other end of the corner, where we have a cryo lung biopsy, before going to the cryo lung biopsy, we have a wonderful team of multidisciplinary teams, what we have in Aster CMI. I think we have a radiologist colleagues. Actually, we'll always have a discussion in terms of whether should we need a biopsy, what are the most common lobes which can yield us a good results actually. And at the same time, with this mapping of this particular stuff, we go for a biopsy, where cryo lung biopsy can take our yield to as much as 80 to 90%, which has been documented in the literature. When it was involving only one lobe, we have a yield of 60 to 70%. When you have multi-lobe pattern getting biopsied, where our yield goes up to 80 to 82% actually. So definitely going ahead actually, a biopsy which will have a major role to play in terms of getting a multidisciplinary team with added advantage of pathology coming in the picture to get this tissue sorted out so that we can have a diagnosis upfront. Mind you, when we have a discussion about the biopsy part, IPF, non-IPF, clearly that has to be discriminated. If IPF, clear no for any of the surgical lung biopsy or any cryo lung biopsy. Our radiologists have been very handy in terms of getting this decision on board at the earliest when we see the patient. So when you have a non-IPF, then we come to a discussion about whether to biopsy it or not. When we have a CTD to sigma, definitely that will have to be taken as a caution that whether to do biopsy, whether there is going to yield us any additional information or not, which will be discussed on a case-to-case basis.
Thank you. So The next question is for Dr. Richa from Radiology. So we see that radiology plays a very vital role here in the diagnosis of interstitial lung disease. The question is, do you think radiology has a fast-growing niche area for these patients and can deliver more accurate as well as predictable quantification of the disease process?
Thanks, Dr. Srivatsa. Yes, actually, with technology, HRCT and CT has actually revolutionized the way we diagnose these cases. There are two things. One is how, as Dr. Sudhir sir has already said, that qualitative analysis, where you know what pattern of ILD is important. The second is quantitative analysis. Quantitative analysis is where now we have radiomics and machine learning and text analysis which is coming in. What happens is we can actually differentiate the amount of fibrosis, the amount of ground glass densities, amount of consolidations, and as these patients come for diagnosis, you can say then the percentage of involvement of the lung. Then these patients go in for treatment. The patient come back for a follow-up. So these actually help in treatment response, whether the fibrotic component has reduced, has increased, or is stable. The ground glass component, the alveolitis, the acute condition that the patient comes with, whether it has improved or not improved. So this actually helps the clinician to actually take an accurate step, whether the way the treatment is going on is fine. So I think quantitative CT is something which is going to come in the future very soon. It's already in process, but just needs a little more
fine tuning, and then we should be for quantifying the amount of scarring in the lungs. And most patients who are unable to perform, pulmonary function tests to objectively assess what is the extent of damage to the lung. Maybe the CT, I would not say as a surrogate, but definitely as an alternative method to help us objectively assess what is the progress of disease year on year when the patient is on treatment. Now, the next disease which we are going to talk about, so far until a couple of years back, until we had widespread surveys evaluate the epidemiological incidence of various interstitial lung disease in the world, idiopathic pulmonary fibrosis was a very common interstitial and is still a very common interstitial lung disease which we encounter day to day. And even today in ILD clinic, most of the patients, I would say roughly 50% or so, would be belonging to this subset called idiopathic pulmonary fibrosis. But very early on, if you were branded idiopathic pulmonary fibrosis, it would mean that it is a progressive disease with little options available to us. So my question to Dr. Sunil is, what is this idiopathic pulmonary fibrosis? What is so idiopathic about it? Must we dread this disease in today's era of advances as well as medications?
Yeah, thanks, Dr. Vasa. That's a wonderful question actually. Everybody who comes with ILD comes without a sentence at IPF. Everybody thinks that ILD is nothing but IPF. That's a common analogy when I have a discussion with any of our IT colleagues actually who comes in for a consultation for their elders ones actually. ILD means scarring. They come with a package with 3 to 5 years of their life expectations. But unfortunately, it's not so. Because ILD, we need to have a proper methodical way where IPF, when all the known causes have been ruled out, like any drug-induced or any autoimmune disease or any granulomatous disease like sarcoidosis, all these things at the same time rule out other subset of miscellaneous conditions actually, which have been ruled out. The most common idiopathic interstitial lung disease common is the IPF. IPF generally tend to be more so in the elderly population, most common in 6th and 7th decade, more so in the male with a smoking history as a predominant presentation. With this people actually, when somebody with younger age present with IPF, less likely to be a presentation unless until somebody has rheumatic conditions like RA, rheumatoid arthritis, ILD, where you have a UIP subset of pattern, which the treatment for them is slightly different from the usual thing what we generally tend to advocate. IPF, no doubt, when it comes to diagnosis, CT scan plays a crucial role in terms of picking up this IPF, banding them before you could go for any sort of a further investigation or a treatment. IPF, generally we describe this what is called as a bilateral, both the sides of the lung, peripheral, low, with reticulation, with honeycombing, with traction bronchitis. This is a classical nomenclature what we use for IPF. When other conditions have been ruled out by CTD markers, everything is quite negative, we call for IPF. And age, all this thing has to fit into this sort of a IPF. And there are subset of, in case of IPF, there is a probable UIP, There is an intermediate type of UIP and also the unclassified virus. Now, if you go with the nomenclature, if you have a radiologist and your clinician feels that on the straight first discussion that it's predominantly classical of UIP, it's very clear, no biopsy, submit them for any sort of an antifibrotic based on what is the patient's clinical scenario, based on the pulmonary function test, and then take it from there. As compared to somebody with a probable UIP, which is not classical of your low lobe honeycombing or traction bronchitis, actually predominantly a peripheral subpleural environment without honeycombing. Classically, we call it probable. In a probable UIP, 50% of them are hypersensitivity demonitis, means that there is a condition which can be treated with steroids. Now, as compared to something like UIP-based steroids are not indicated as an upfront medication, where we have a better medication like antifibrotics. So, classical UIP, antifibrotics are drug of choice. As compared to probable UIP or congenious other classification of a UIP, we have a steroids also comes up in the picture where 50% is by hypersensitivity demonitis, which can be handled much better with the medication. So, UIP, so the thing is team approach to how to segregate this UIP pattern and brand them as IPF so that we can sail through the whole process in terms of improvement in the quality of life and what is the thing to expect in the future in terms of nutrition, rehabilitation, and end of spectrum where lung transplant options, if somebody is fit enough to, can be offered in this particular patient who has a rapid progression in their lung functioning capacity and the symptoms getting bad very early.
So I think all of you heard how Dr. Sunil stressed the importance of the multidisciplinary team in coming to a conclusive diagnosis, and very well it forms the cornerstone of diagnosis of interstitial lung disease. Because of the complexities involved, you see that radiology, sometimes blood tests, and even the biopsy might not always be conclusive. So even though we don't have a gold standard for diagnosis of interstitial lung disease, the MDD always forms the silver lining or the silver standard for diagnosis, and this is the best standard we have worldwide to diagnose interstitial lung disease. Now we have a boom of various molecules in the market which are used to treat interstitial lung disease. Our knowledge of various pathology and pathogenesis of this disease is improving fast. We have a pipeline of medications that are awaited, and it's all exciting in the future that these patients will have access to many more drugs that can help to live a life with good quality and also less suffering. So when we're talking about molecules, basically we're looking at two important pathology scenarios in interstitial lung disease. On one hand, we have inflammation, aberrant inflammation that is gone out of control. On the other hand, we have a healing process which has gone out of control, leading to excessive scarring and basically compromising the very lung that helps to breathe. Now, my question next is to Dr. Chetana. We talk about these new molecules to treat these conditions. What can we expect from such treatment, and are we supposed to monitor these patients regularly, and what are the outcomes we have seen so far with these kind of molecules?
Thanks for that question, Dr. Srivatsa. So, for a long time, the mainstay of treatment of patients with CTD ILDs had been medications like steroids, cyclophosphamide, or mycophenolate mofetil. But now we are in the biologic era. So there are a number of biologic drugs, by which I'm referring to drugs like rituximab, tocilizumab, and abatacept, which have revolutionized the treatment of a number of autoimmune conditions. So to give you an example, treatment of rheumatoid arthritis has really, our patients are now lucky to be in this biologic era. So patients who don't respond to our traditional drugs are started on these biologics early on. And patients who had rheumatoid arthritis associated ILD who were initiated on biologic drugs early for their arthritis, we found that their ILD actually stabilized. So although there is no permanent cure, unfortunately, the ILD, the PFT is actually stabilized, the lung volume stabilized. And there is a little prevention of progression of ILD. even in systemic sclerosis, so there are a number of trials that have been conducted on drugs like tocilizumab and rituximab, and there is promising response of ILD to these medications. And still, like I said earlier, the key is to diagnose these patients early and start them on treatment early, including biologics. So a number of patients with different conditions like myositis, rheumatoid arthritis, scleroderma are all responding to rituximab, and the ILD actually stabilizes. So I would say patients are now with ILD are now lucky to be in the biologic era, as there seems to be a promising response to biologic drugs.
Thank you, Dr. Chaitman. So with regards to diagnosis of interstitial lung disease, we know that the interstitial lung disease is basically pieces of puzzles that we put together to come to a conclusion. In many instances, I think Dr. Sunil will agree to me, we have encountered patients who have been labeled idiopathic pulmonary fibrosis from all over the country. And when they come to us, we sit at our MDT clinic, discuss, and then deliver a cryobiopsy. It comes out counter-wise, basically coming to a diagnosis of hypersensitivity demonitis or something odd out of the box. And we have seen this happen quite a number of times. And there's enough data now to substantiate that if you take radiologically diagnosed idiopathic pulmonary fibrosis and subject them to, biopsies, in about 50% of the cases you will diagnose hypersensitivity pneumonitis. That's quite surprising. And so my question to Dr. Sudhir is that, so what has your experience been with radiological diagnosis standalone for interstitial lung disease? Whereas when you're sitting with us in an NDT team and seeing the diagnostic or the dynamic evolution of the clinical diagnosis, do you think that these parameters become vital to an interstitial lung disease diagnosis? What's your thoughts on this?
Yes, definitely, Dr. Srivatsa. So to begin with, I will just maybe brief you up with how a radiologist goes about typing or classifying the interstitial lung disease. So generally we use American Thoracic Society and European Respiratory Society international classification for interstitial pneumonias. And then we have those with associations, like it could be connective tissue disease associated ILD, or it could be occupational disease causing ILD, or a drug-induced interstitial lung disease, or it could be something like hypersensitivity pneumonitis, which is otherwise also called as farmer's lung or bird fancier's lung. Okay, so I mean we have say over 100 interstitial lung disease, so our final aim is to pinpoint that one final diagnosis. So generally is using HRCT, we are able to look for some patterns like imaging patterns what we saw, and these diseases will have some classic imaging constellation of these patterns what we saw. Like say for instance, like in UIP pattern, we have honeycombing, reticulations, more of peripheral and basal predominance. In non-specific interstitial pneumonitis, we have mild interstitial thickening, ground glassing, but there will be a subpleural sparing. Then in case of sarcoidosis, we might see some nodules along the fissures, like a beaded appearance along the fissures. So with mediastinal enlarged nodes, which is a pointer towards sarcoidosis. And in like hypersensitivity pneumonitis, like the bird fancier's lung, so we might see some kind of centrilobular nodules, and then we call something called as a head cheese sign, where there is a mosaic perfusion, normal lung and ground glass densities all together in one section. So these are few imaging signs which helps us to come to some mark. I mean, it gives us a pointer toward diagnosis towards some of the disease. But unfortunately, we have few diseases where have a mixed appearance, like hypersensitivity pneumonitis can have sometimes UIP or NSIP patterns, similarly connective tissue diseases, and sometimes fibrotic NSIP can mimic like an IPF. So this is the time when we actually, like the Aster ILD clinic and the MDT plays a huge major role, I can say, and this is when things are discussed, And then whenever we are not certain, we are just open to them, and then we will ask our interventional pulmonologist, Dr. Sunil, Dr. Srivatsa, to really go one step further, go in for a cryo lung biopsy. And this particular biopsy taken will be actually seen by our pathologist, Dr. Vidya and Dr. Tripti, who are a part of ILD team. So, I mean, they are the ones actually helps us to give final histopathological diagnosis. So I think all this put together, so we have seen in many instances where like IPF appearing thing has turned out to be HP, or sometimes CTD, ILD presenting as NSIP. I mean, all these things, I mean, definitely, I mean, these are real challenging times, but I think this ILD clinic as such has helped us to actually break down and to get to that #1 diagnosis in each of the cases.
Thank you, Dr. Sudhir. So what Dr. Sudhir is, to sum up, if I have to say, contrary to the usual belief that too many cooks spoil the broth, over here too many cooks actually are enriching the broth and basically giving you a better diagnosis. And to briefly talk to you about a topic of interest, that is hypersensitivity demonitis, because this has been splashed across the media very frequently after the Indian survey showed that hypersensitivity pneumonitis is the most common interstitial lung disease in our country, probably because of our lifestyle and environment, that we're increasingly exposed to certain types of organic dust, and most of our population living in rural India, as well as exposed to certain types of animals as well as birds. We are seeing that, especially in the urban setup, exposure to molds in air conditions, in air vents, coolers, as well as pigeons and their feathers, pigeon droppings, all these things pose as a significant risk for developing scarring in your lungs, which you might not even have thought of. And the other things are, our pillows and other things which have usually certain types of proteins in them because of the cotton and other pigeon feathers or bird feathers which they use, can act as an instigating allergen to start off an inflammation in the surrounding area around your airways. And this cascade can go uncontrolled, basically scarring the entire lung. And we have encountered many such patients in their mid-30s or 40s who have even gone to the extent of depending on oxygen, unable to perform their daily activities. And to our credit, we also have a gentleman whose life we saved after very brave lung transplant surgery that was done to pull out his old damaged lungs and give him a fresh pair of lungs. And thankfully, this gentleman is active today. He's able to walk without oxygen for 2 to 3 kilometers, and he's on constant follow-up even up till today. So, like Dr. Sunil pointed out earlier, lung transplant can be one of the turnarounds for such patients, and ILD does not necessarily mean a dead end. And this point I stress again. And with the newer molecules which Dr. Chetana was stressing, the newer biologics that are in a pipeline, as well as a transplant option, I think ILD patients need not frown. They have much more to look forward to than the labels that were stuck on them many years back. Now, with regards to people who have ILDs in their family and are a bit afraid whether this is a genetic tendency, yes, some of the ILDs do have a genetic tendency, and we have seen even idiopathic pulmonary fibrosis can happen in families. But is there a way can we diagnose these interstitial lung disease early? On one hand, we need to know whether there are specific radiological protocols we can establish to diagnose these patients early, or are there genetic blood tests that can pick up these patients early? So my question to Dr. Richa is, does screening people with a family history with radiology basically help in early diagnosis of interstitial lung disease?
Okay, yes. It actually helps because Idiopathic pulmonary fibrosis is basically about 10 to 20% of them will have familial preponderance, as in you have people who have family history in cases of interstitial lung disease and interstitial pulmonary fibrosis specifically. And as we have all talked in the last half an hour, that IPF is progressive. So why not stop it or before it is progressing and just pick up the early changes, which are predominantly seen on the CT, and the patient becomes symptomatic only when the CT becomes really bad. The patient will not come to us when the CT is normal and the symptoms will not come first. The CT changes come first. So you have low-dose CT screening, because everybody is going to be talking about radiation exposure and all whenever you talk about CT chests. But with low-dose CT, screening patients who already have been diagnosed with IPF, the first degree and the second degree relatives, picking up early abnormalities like interstitial lung abnormalities, the minimal or the subtle changes in the reticulations, which we already spoke about. All these things can be picked up early, and once we pick up early, we can always follow them up with different pulmonary function tests or the blood work of the genetic mix, and then it will definitely help, though it is it's not a protocol which is already set, but there are people who are actually talking in the US and the European societies to get screening CT chest as a tool for detecting IPF early in patients with familial IPF.
Okay. So that again, to conclude, there are ways in which we can help the family and screen near and dear ones, people at risk especially, and even occupational risks. You know, there are certain people who go to certain occupations which pose a risk to develop scarring in the lungs, and there can be significant effort in educating these people on respirators and how to avoid these allergens as well as instigating agents. At the same time, screen and prevent these diseases early. Now, doctors.
Yeah, one thing, I just want to interrupt, but sorry, Dr. Vatsa. Basically, to end the whole program actually on a highly encouraging note, actually, I would like to call upon Dr. Vatsa actually, like to discuss a few points about when do you refer the patient for a lung transplant.
Okay.
That's the most common thing actually what anybody encountered in ILD, when somebody was a 60 years or 70 years age with recurrent hospitalization, with all the limited armamentarium what we have in terms of medication like antifibrotic, which may not be of that much benefit to get the good quality life, on top of a COVID, which is already making the equation more complicated actually. In this inflammatory surge actually, where do you think where we can draw a line in terms of which is a subset of patient who would always be benefit with a lung transplant with all the experience what we have it in a closet?
Okay. So when it comes to interstitial lung disease, there is a panorama of presentation. We have patients who are one end sitting without oxygen, on the other hand we have patients who are sitting at home with about 5 to 10 liters of oxygen, unable to even do activities of daily living. So listing a patient in a lung transplant list does not necessarily mean the patient is going to receive the lung within a month's time or within 20 days or the very next day. It only means putting the patient on the list so that we can prioritize patients based on the level of severity of the illness if time comes, and give the apt patient the lungs that we receive, which if possible is gone through various protocols of the transplant program. Basically, we match the patient as per blood grouping and other factors. So all these factors come into play because lung transplant itself is a big discussion point. And so, but from the purview of ILD, we know that a lot of patients will ultimately land up on a lung transplant list when they have progressed sufficiently and medicines have failed to keep their disease in check. And in such a situation, we do have a very elaborate and diligent workup protocol here at Aster ILD Clinic. We discuss this with our transplant team in detail, and we identify patients that are at the risk of progressing or having repeated exacerbations requiring hospital admissions. And we have also seen a similar kind of picture, especially in the present COVID scenario. So I don't think that we need to draw breaks or put roadblocks to patients who are requiring life-saving surgeries, even though in the midst of pandemic, our transplant team is already performed transplants for patients who have had COVID-associated lung scarring. I don't see the need to draw breaks for patients with other types of fibrosing ILDs, especially in the present scenario, for not going on to the list. I think as long as you're in the list, you are at least one step away from getting the lung when time comes, which can help you have a better quality of life. And in some instances, we have seen that these patients even completely come off their oxygen immediately and they are able to do their really daily activities even before the disease hit them. So I think lung transplant, I will save the discussion for another session, but lung transplant is a workable solution even in the COVID pandemic for such patients with scarring lung diseases. Thank you. So to conclude, I must thank all of us here, Dr. Chetana from Rheumatology, Dr. Sudhir Kale from Radiology, Dr. Sunil from Pulmonology, and Dr. Richa from Radiology for being here with us to basically encompass the various, hubs and spokes of a proper MDT. These are my pillars, I have to say, of the MDT clinic, without which the present Aster ILD clinic would not have established a success story, and we will continue to deliver the best and advanced care possible for patients with this scarred lung disease, and we have all possible treatment modalities that we could deliver to these patients. Thank you.